Hello everyone, I am Dr. Professor Bhupendra Chaudhary, Senior Consultant Neurologist from Meerut, Uttar Pradesh. Today I am going to discuss very important clinical aspect of management of epilepsy and that too in a pregnant female. This is a challenging issue as far as the epileptologist and the concerned gynecologist are being there because a complexity exists between the epilepsy itself, the mother, the fetus, and the use of anti-epileptic drugs, which are the cornerstone in the management of this important issue. Now, before starting the clinical scenario, I would like to narrate some important issues that there is an effect of epilepsy both on the mother as well as on the fetus. Epilepsy produces its deleterious effect on mother as it can produce eclampsia, premature labor, maternal hypoxia, then maternal trauma. There is high chances of maternal mortality, miscarriage, and cesarean section. On the other hand, epilepsy on fetus produces effects like prematurity, stillbirth, bradycardia, intracerebral hemorrhage, then developmental delay, low Apgar score, and so many and so forth. So it's very important and at times difficult to manage such an individual or such a patient who are non-epileptic and who are on anti-epileptic drugs. So our aim is to get a clear-cut pregnancy and a normal healthy child. So the main issue is that of use of the anti-epileptic drugs in pregnancy because these drugs produces some deleterious effect on the developing fetus in form of what we call as teratogenicity. Or in other words, they are termed as anti-epileptic drugs embryopathy. All the drugs which are available in the market have got some potential to produce this teratogenicity in the developing fetus. The first-line anti-epileptic drugs, they are more notorious in producing this effect. So if we'll take on the first line, if we take phenytoin sodium as the drug to be used in pregnancy, then there are chances of, you can say, teratogenicity in form of distal digital hyperplasia and cleft lip and cleft palate. And if sodium valproate is in the use, then there are chances of neural tube defect in form of meningocele, meningomyelocele, myelomeningocele, and so many and so forth, along with anencephaly. And if the female is on carbamazepine or oscarbamazepine, then there are chances of the most dreaded and contraindicated drug which is not now available for its use was thalidomide, which produces phacomelia. This drug is contraindicated and banned in present scenario for its use in epilepsy. And if the patient is on newer anti-epileptic drugs like topiramate, then there are chances of effects like hypospadias and some congenital heart defect as well. So amongst the basket of these anti-epileptic drugs, we'll have to choose the most efficacious with minimal side effect, especially to the fetus, what we call the teratogenic potential amongst all the available anti-epileptic drugs. So the issue is which anti-epileptic drug should be used. Carbamazepine or oscarbamazepine enjoys the reputation of being the safest anti-epileptic drug to be used in pregnancy in dosage of 10 to 40 milligram per kilogram body weight. Or if the patient is hypersensitive or allergic to carbamazepine related compounds, then another choice, which is at times better than oscarbamazepine, is levetiracetam. Levetiracetam should also be used in the same dosage 10 to 40 milligram per kilogram body weight per day. For any reason, if the seizures are not being controlled on either of these medication, and if we require some add-on anti-epileptic drugs, then lamotrigine is the preferred choice. Lamotrigine in dose of 1 to 4 milligram per kilogram body weight is used in pregnancy. Here one thing is very important. we should avoid using sodium valproate, not only in epileptic patients who are pregnant, but also in patients who are in use of, say, migraine prophylaxis. So we should avoid the sodium valproate because it lies in category X drug for the use in pregnancy. So as far as possible, we should avoid sodium valproate in pregnancy. Now, there are three clinical situations which are very commonly seen in our day-to-day practice, which are at times very difficult to manage. I'll take all the three situations. Number one, if a patient who never had an epileptic attack become pregnant and she had a first seizure during the first trimester of pregnancy, means an individual who never had any seizure activity in the first trimester of pregnancy developed a seizure. This is really a threatening situation for the patient, for the family members, and for everyone. So how to proceed in this situation? We should take a detailed history regarding the onset of seizure, whether it was a provoked or unprovoked seizure. We should also know any past history or any history of febrile seizure. And by routine investigation, we should try to exclude the common cause like low calcium, low magnesium, and even hypoglycemia. For investigation, we have got two modalities. One is EEG, which is very safe in pregnant as well as in non-pregnant. And the second, amongst the neuroimaging, we have got two choices. One is CT scan and second is MRI brain. In first trimester of pregnancy, MRI brain is a preferred modality of treatment of investigation as compared to CT scan. But if for any reason MRI is not available, then we can go for a CT scan with shielding of abdomen. Now, even in first trimester, we have established that yes, the patient has got an epileptiform discharges. We should start anti-epileptic drug. So anti-epileptic drugs are not a contraindication of its use in first trimester of pregnancy because any seizure in first trimester produces more deleterious effect than any teratogenicity with these anti-epileptic drugs. So we'll have to discuss in detail the potential of teratogenicity in these drugs. We'll have to explain in detail and we'll have to take in writing regarding all the possible teratogenicity and any sort of negative outcome to save our skin from any medical legal issue. Now, second situation, if the patient is a known case of epilepsy and she is willing for she is conceived and she is willing for a baby, so here we are dealing with the case of planned pregnancy. So in that situation, we'll have to explain in detail regarding the various, you can say, teratogenic potential of the anti-epileptic drugs, and we'll have to discuss the effect of mother as well as on the fetus with the use of anti-epileptic drugs. In this situation, we should also try to reduce the dosage of anti-epileptic drugs, or even we can plan to withdraw these anti-epileptic drugs if the patient was seizure-free in previous 3 to 4 years. Now, we should start the medication if the patient seizure were controlled even before the conception, then we should continue with the same anti-epileptic drugs during pregnancy. It is not recommended that you will have to change the anti-epileptic drug to either carbamazepine or levetiracetam or even to lamotrigine. If the patient is controlled on phenytoin sodium, then we should not touch phenytoin sodium. We should continue the same medication throughout the pregnancy. And we should start a preconceptional folic acid in all cases of epilepsy in pregnancy. And the word preconceptional carries a huge meaning. Preconceptional means even when the patient is not aware that she is pregnant, because the neural tube closes by 28th day, even before the patient is known that she has conceived. So we'll have to use a prophylactic anti-folate drugs and folic acid. Number one. Number two, that the folic acid which is used should be in 5 milligram per day dosage. And if a patient who is a known epileptic comes to us with having a planned pregnancy, then we should start the folic acid as early as possible to prevent any neural tube defect in future. Now, case 3. If the patient is a known case of epilepsy and she turned in between after a couple of months that she is having a pregnancy of say around 6 to 8 weeks, even in such situation, we'll have to continue with the same medication and we'll have to start the folic acid even at the time when she narrated that or she had disclosed that she is pregnant now. And that folic acid should be continued throughout the pregnancy. Now, with each of these situations, there are some important things or some important investigation which every patient should get in the second trimester. First is serum alpha fetoprotein levels. The assessment of these levels are an indicator of underlying neural tube defect. Higher the levels of alpha fetoproteins, more are the chances of neural tube defects. So we should get these alpha fetoproteins in mother serum at around 16 to 18 weeks of pregnancy. And second important modality is 3D or 4D ultrasound around 20 weeks to delineate out any congenital anomaly in the developing fetus, because we have got time to have a medical termination of pregnancy if any such issue arises. Now, it has also been recommended that every patient who is on anti-epileptic drugs and who is pregnant should get anti-epileptic drugs level at least once in each trimester, then before labor. And if unfortunately if the patient develop a breakthrough seizure during pregnancy, then also we'll have to go for the drug levels. And a minor seizure activity does not qualify for an increase in anti-epileptic drug dosage, and we should stick on to the dictum that we'll have to treat the seizure, not the anti-epileptic drug level. Even if the patient has got a seizure and the seizure and his anti-epileptic drug levels are low, only in that situation we'll have to increase the drug dosage to attain an optimal therapeutic drug level. Now, with all these precautions, we can move towards the labor, and even if a patient develops a seizure during labor, it should be managed like an acute attack of seizure by use of IV lorazepam or IV diazepam, followed by maintenance, whether in form of phenytoin sodium or sodium valproate or levetiracetam or even phenobarbital in dosage of 20 mg per kilogram body weight. Now, once we are able to have a normal delivery, then the most important aspect which is being asked everywhere, what about breastfeeding? Breastfeeding should be encouraged in every patient who is on anti-epileptic drugs, because the benefits of breastfeeding are much more than any, you can say, side effects to the newborn while on breastfeeding. But if the newborn develop, you can say features like dullness, drowsiness, and even poor suckling, then early weaning is advisable. And these newborns should also given 1 milligram of injection vitamin K early in the early period of their birth to avoid any hemorrhagic related complication. So we should encourage the breastfeeding as far as possible. So with use of these proper anti-epileptic drugs at proper time and choosing the best one with minimal side effect, we can have a very safe pregnancy and a healthy child in more than 90% of the cases. Thank you very much.